Welcome to the Grassroots Health webinar series. Scientists answer your questions. Thank you so much for our delayed start and your waiting this morning. I'm sorry, Dr. Wagner is just now getting on the phone. This is Carol Baggerly, the Director of Grassroots Health. Grassroots Health primary mission is to help solve the vitamin D deficiency epidemic with a combination of education and testing everyone's vitamin D serum levels, and through our Vitamin D Action Project. Today we are definitely featuring Dr. Wagner of the Medical University of South Carolina and co-author of a very, very important randomized trial showing both the safety and the effectiveness of giving a pregnant woman 4,000 international units a day during her pregnancy. If you take a look at that green box that's on your main screen there, it indicates that the current estimated average requirement, which is right at 400 IU a day, is comparatively ineffective. Dr. Wagner will go over that in great detail for us this morning. Also on that page right there, there's a note that says download the dosing chart. Dr. Wagner, after her talk, will be giving us answers to the questions that have been submitted, and many of the questions, I will tell you, were really about dosing. And we have a chart which is on our homepage, which you can download at any time. Looks like what I have just now presented, where you can see, for example, if you happen to be at 20 nanograms per milliliter, you could get to 40 on average by taking about 2,600, or make that 3,000 international units a day. This is, as noted on that chart, the average intake for people that weigh about 150 pounds. If you weigh more, you need to take more, and most likely, or certainly if you weigh less. With Dr. Wagner's study, they gave 4,000 IU a day, and if you kind of move that line over there to write out, say you're still starting at 20 nanograms per milliliter, if you took 4,000, on average, people would get to be about 50 nanograms per milliliter. So we think that you will find this dosage chart handy for you in taking a look at your own weight and your own time for this. Okay. So we thank you for this, and we are still waiting for Dr. Wagner. So it will be just a second. So if you wish to take a look. Hello, Dr. Wagner. I'm so glad you're there.
Yeah, I'm here. Sorry.
All right, thank you.
Yeah.
Well, I just introduced you to this lovely group of people who are listening already, and I've gone over our first chart, and we are ready for you to talk to us a little bit. So,
okay.
Are you ready? Go.
Sure. Okay.
All right.
Well, thank you very much for attending this webinar. We are very interested in your questions, and we're trying very hard to find out more important information about vitamin D requirements in the prenatal stage, and as well as throughout pregnancy and during lactation. And we're going to focus today on the safety of vitamin D during pregnancy and what your vitamin D requirements are. And if we can have the next slide.
Dr. Wagner, did you want to go directly to the questions?
Oh, yeah, I just, I thought there was another slide that we had, but we can certainly, I just want to tell you what we have. We've been studying vitamin D during pregnancy since our first study began in 2004. Prior to that, we had studied lactating women and their vitamin D requirements. And in the NICHD, which is the National Institutes of Child Health and Human Development, which is an institute at NIH, and we had received a grant from them, and that study started in 2004. We had a second study that began in 2006 that was funded by the Thrasher Research Fund, and that study took place in two community health center networks in South Carolina, where women were very vitamin D deficient. And so the results of those studies have been published. The NICHD trial was published now over a year ago in the Journal of Bone and Mineral Research, And the second one was just published this past December. That's the results of the Thresher Research Fund study, and that was in the American Journal of Obstetrics and Gynecology. So I urge you to find those articles to really get a better sense of those studies and the results. And with that in mind, I'll answer your questions. So if we can move to the questions, that would be great.
We certainly can. We had an entire set of questions for Dr. Wagner today, so I think that we will just proceed. Number one, which is right there, is can you comment on the effects, positive or negative, of taking 4,000 IU of vitamin D per day as part of a regimen before getting pregnant? Would this theoretically increase the chances of getting pregnant, or would there be a negative impact?
So we did not study in our 2 pregnancy studies women before they got pregnant. So those studies began at 12 weeks of gestation. However, the Institute of Medicine does list 4,000 IU as safe as the upper limit that they, so you really are not, even with the most conservative measures, you can safely take 4,000 international units a day. There are anecdotal reports that women who have difficulty getting pregnant can benefit from having a therapeutic or actually a normal range vitamin D level. So that would be your total circulating 25 hydroxy vitamin D. And we have, and there are some studies that are just coming out that have looked at infertility and vitamin D deficiency with an association of improved fertility. However, the whole issue of fertility is multifactorial, and I would urge you to normalize your vitamin D level. We would prefer to have that to be at least 40 to 50 nanograms per ml, in that range. And I would, you know, and then certainly depending on why, you know, you're having difficulty getting pregnant, that there are other issues besides vitamin D status. I would say that during pregnancy we had absolutely no safety issues associated with the 4,000 IU per day in any of our pregnant women. And in fact, there was always a trend in the NICHD trial and in the Thrasher where there were fewer complications of pregnancy associated with the higher dose group of 4,000 compared to, in the NICHD trial, 2,000 and 400. And we also found, as a function of 25 hydroxy vitamin D achieved, that we did see reduction in preterm labor, preterm birth, and infection. That was notable in the Thrasher Research Fund study, and also held up when we combined the data sets for a paper that's now in press in the Journal of Steroid and Biochemistry. All right. Excuse me, I can't really think of any negative impact of being vitamin D replete.
That's good. Number two, I've had multiple early miscarriages, don't go beyond 5 to 6 weeks. Is it possible that I'm low in vitamin D and this could be causing these early miscarriages or be causing low progesterone?
I think that that is possible, and I would urge you to have your total circulating, your 25 hydroxy vitamin D level checked. But as I mentioned, there are multiple reasons for infertility and miscarriages. I would also make sure that you've had genetic testing because it may be that the early miscarriages, it could be a genetic reason for that. But certainly no one should be vitamin D deficient. For whatever reason, we shouldn't see that. We should aim to have vitamin D sufficiency, just like you wouldn't want to be deficient with thyroxine, if as far as your thyroid, or you wouldn't want to have low levels of niacin in your body. So this is also true of vitamin D. The only issue, of course, is that because we've evolved as humans using the sun to generate the vast majority, more than 90% of our vitamin D comes from the sun, unless you take a supplement. All the other nutrients you can get through your diet. Unfortunately, with vitamin D, unless you're on a supplement or you go out in the sun, you cannot get enough from your diet. And so what we're seeing is just mass vitamin D deficiency throughout the world. But I would urge anyone to have their vitamin D level checked.
What is vitamin D doing in the placenta? That's a big one.
So that's a very big one. I'm just going to tell you that vitamin D is everywhere. It's not only in the placenta. But what happens is the vitamin D is converted to 25-hydroxy vitamin D, including in the placenta, and that it is transferred to the fetus. So the fetus actually converts the 25-hydroxy vitamin D to 1,25-dihydroxy vitamin D. So that's the active metabolite of vitamin D. And it is really essential. What we also know is that in women so throughout pregnancy, your active form of 125 is about 2.5 to 3 times what it is in the non-pregnant state. And it appears that the placenta is responsible for increasing your 125 slightly, but it appears that most of the 125 is being made from the kidney, in the kidney. And we're just beginning to understand the role of 125 during pregnancy. We think it has something to do with immune tolerance of the fetus, but certainly more research needs to take place. And in our study that we're just beginning, funded by the Kellogg Foundation, we will be looking at that very question. What is vitamin D doing in the placenta? So stay tuned.
What reference range do you use for pregnant women as lab values? What's the upper limit of supplement dosage you recommend in pregnancy? And what dangers are associated with a pregnant woman's being below normal with vitamin D?
Okay, so the reference range for pregnant women, what we showed in our NICHD trial that was published in the Journal of Bone and Mineral Research, Dr. Hollis was the lead author on that, and he's my colleague. But what we found in the 350 women who completed the trial was that in order to optimize the conversion of 25-hydroxyvitamin D to 125, which is the active hormone, a woman needs to have a level of at least 40 nanograms per ml. Therefore, during pregnancy, we urge you to take the amount of vitamin D, or to have sunlight exposure. Again, you have to weigh the possible deleterious effects of sunlight. But however you get your vitamin D, whether it's through supplement or sunlight exposure, we recommend during pregnancy especially that your level is at least 40 nanograms per ml. So what are the dangers associated with a pregnant woman's vitamin D levels being below that? We certainly have evidence in the literature that vitamin D deficiency is linked with states like pregnancy-induced hypertension and more severe aspects of that, preeclampsia, which is essentially a vasculitis where you have hypertension, you start losing protein, you have renal and liver dysfunction. And while we saw a trend in our 2 studies, we were not powered for preeclampsia, but we certainly saw, based on 25-hydroxyvitamin D levels, that the risk of preterm labor, so spontaneous preterm labor, preterm birth, and infection was higher in those women who had levels that were lower. So for every 10 nanograms per ml that you increase your vitamin D level, we saw a reduction in the rates of those disease states. So I would urge every pregnant woman and those women who are planning to get pregnant to have a level of at least 40 nanograms per ml. And
Number 5, excuse me.
Oh, I'm sorry. And then they were asking about what was the upper limit of the supplement dosage.
Yes.
So it really, the data suggests that you should be able to achieve vitamin D sufficiency on a supplement, daily supplement, below 10,000. We have not studied 10,000. We've studied 4,000, and all the women that we studied were able to achieve a level, if they took their vitamin D supplement, of at least 40 nanograms per ml. I would say, though, that there are going to be some women who, especially those women who have inflammatory processes, obesity, higher BMIs, if they have malabsorption, if they have like Crohn's disease or ulcerative colitis, they may need higher amounts of vitamin D to achieve those levels. And so that becomes essential to get your levels.
And I think the message is very clear that what we are trying to achieve is what the serum level is, and essentially to take the dosage necessary to get there.
Exactly.
Right. On number 5, I think you've already answered the first part of that, but they talked about also what's the optimal cord blood level.
So the cord blood level, it's about 70% of the mothers. And so we don't really know what's optimal in the newborn, but we do know that if a mom's level is at least 40, that her baby, her newborn baby's level will be at least 20 nanograms per ml conservatively. And we will probably have a much better idea of that in the next 5 years with more studies. But we can say that at least 20 nanograms per ml is the goal. And some people would even think that it should be at least 30 nanograms per ml.
Whoa, excuse me. Went too far too fast. I'm sorry.
That's all right.
We will get the rest of our slideshow here back again. All right, question number 6. I'm sorry. Through the winter months, what do you feel is an adequate vitamin D level for a pregnant mother to have in order to deliver a healthy baby? And what doses of vitamin D should be taking and what type? So is there a difference in the winter?
No. I mean, what it means is certainly, depending on where you live, if you're at the equator, winter months don't really make such a difference. However, even in sunny South Carolina, we're at latitude 32 degrees north, we have seasonal variation, so that your levels in your blood are going to be usually about 10 nanograms per ml higher during the spring and summer months compared to the winter. However, if you never go outside or if you apply sunscreen, then you're not going to see the seasonal variation. And it doesn't matter what time of year, you should have at least, when you're pregnant, at least 40 nanograms per ml is what you should aim to achieve. And I would really prefer to see that in place before you get pregnant, so that you're entering your first part of pregnancy with a normal level. What doses of vitamin D should a woman be taking during pregnancy? So we showed in both of our studies that 4,000 international units a day was safe, and it's effective. What type? We studied the vitamin D3, which is cholecalciferol, and in some individuals that appears to be better in the conversion from to 25-hydroxyvitamin D. So, and it's also the most readily available. So that's really the answer to number 6.
All right. Number 7, is it okay to supplement with high levels of vitamin D in the first 12 weeks of pregnancy?
Well, it depends on what you mean by high levels of vitamin D. So,
good point.
So what we're really saying is you need to have a normal vitamin D level in your blood. And so really, if you've been very, very deficient and you suddenly start taking 4,000 international units, you will see a tremendous increase in your vitamin D levels if you were to check them within 3 or 4 weeks. So we had some women who were really in the single digits or the teens, so well below the 20 nanograms per ml that the Institute of Medicine lists as the normal level, or at least the level that's not deficiency, let's put it that way. And when they were randomized to 4,000, their levels were then, in the next month, had jumped up to the high 80s, low 90s. Now, there was no toxicity found in that. Some people might think that it's better to bring up your level gradually. I don't really know the answer to that. I think that you could certainly be more conservative, and if you're quite deficient, so levels below 20, you could go to 2,000 IUs a day for a month and then go up to 4,000. But there's no evidence to suggest that you know, that these doses of 4,000 are going to be toxic, which is what I guess the person is getting at when they say, is it okay? Now, we didn't study the first 12 weeks of pregnancy, but again, other people who have looked at levels, what you're really trying to achieve is a healthy vitamin D level in your body, and whatever dose is necessary to achieve that is what you should take.
All right. Number 8, to some extent, as a reiteration, can vitamin D be prescribed in the first trimester? Is there any harm to the fetus? If you're taking calcium and vitamin D, as the total gets to about 3,000 IU of D3, is it safe? So I think
so we did not study the combination of calcium and vitamin D supplements. I think that what we did find was really almost 100%. It was rare, so probably at least 90% of the women in both of our studies were getting enough calcium through their diet. So in the United States, women are typically not having issues with calcium, even among our African American women who may be lactose intolerant, at greater risk of that. So I think that you should really look carefully at what your calcium intake is, and I can only recommend a vitamin D supplement. You know, that's what we studied. And I think that these permutations of 1,000 of calcium, 3,000 of vitamin D3, you have to realize that vitamin D has effects on the body that are distinct from the calcium metabolic pathway. And that really the vitamin D that we're talking about is really the non-calcium. We're looking at the immune function and the modulation of that immune function through vitamin D. And calcium is not a part of that. So I would just say there's not a lot of information out there about calcium and vitamin D supplements combined, and I would really enter that path with care.
Thank you. Number 9, I read that suggested amount of D is around 4,000 IU. Is it better to take it in one capsule or split it in several doses together with multivitamins, or separately, or different times?
So we studied our vitamin D was given once a day. Given the half-life of 25-hydroxy-vitamin D, which is 2 to 3 weeks, and the half-life of vitamin D itself is about 12 hours. So what you're saying is, does it really matter? And I think it's really what matters is the steady state of 25-hydroxy-vitamin D. So, if you're the kind of person who likes to split in several doses, I guess you can do that. I don't think there's a problem with that. But if it's hard for you to remember, then I would just take the one capsule. There are also gummy bear preparations that are on the market, and sometimes women, when they're pregnant, have difficulties tolerating the horse pills that might be available. There are some very tiny gel caps. Whatever kind of mode of vitamin D supplementation agrees with you is the one that you should take. As far as pairing it with your multivitamin, I don't see that as a problem. You know, again, if you have an issue with fat malabsorption, if you have cystic fibrosis or one of the autoimmune GI illnesses like Crohn's disease or ulcerative colitis, then it may be that you do need to split your dosing or modify your intake because certainly maybe time it with your enzymes and so forth. So I think that, but for the most part, for 99% of the women, you can really take it once a day effectively.
Thank you. And onwards, we still have some more, Dr. Wagner.
All right, okay.
I think the first one we've already answered, but are there certain forms of vitamin D supplements that are preferred for pregnant and breastfeeding women, certain brands or ways? And will there be a webinar about postpartum? Haven't discussed that yet, but how about the supplements for preferred types?
So I think that, again, it's really a personal option, but it should be, the vitamin D should be made, that you purchase should be made by someone who has quality control. So it may be that you get a brand that's half the price of some other brand, but you have to make sure that it is a good quality manufacturer. They have tests in place and so forth. I mentioned that the vitamin D3 is the preferred supplement. It's much easier to get. Vitamin D2, excuse me, appears to have some difference in terms of its metabolism. But for those women who are vegetarian, perhaps they would prefer the vitamin D2 because that is plant-based. The vitamin D3 is typically from marine, based, so from the fish oils. And there are some people who are allergic to fish oils and cannot tolerate the vitamin D3, and so you'd have to look to make sure that the vitamin D3 was, that it was separate from the fish oil. So those are some considerations. And as far as postpartum, I would say for breastfeeding women, our study that we are just in the process of now presenting, and we're hoping to have published by the end of this year, breastfeeding women, they give about 20% of their vitamin D is given to their baby through their milk. And we've studied the vitamin D3. We've also studied vitamin D2, but the levels that we achieved of the 25-hydroxyvitamin D were less than what we found with the vitamin D3. Clearly, that's another discussion for another webinar.
All right. Similar type question here. If someone already has optimal levels, can a dose of 5,000 IU be taken once weekly instead of daily?
Well, for those of us who are in the vitamin D field as clinicians, we really prefer to see daily intake because it's more physiologic. And where we evolved around the equator, you were having sunlight exposure and a daily dose of vitamin D. Now, it's true that you can take higher amounts of vitamin D weekly to achieve, on average, and again, this is the point, on average, what you would get when you took a daily dose of 4,000 IU. However, it's really what you're seeing are these wide fluctuations with very significant peaks and then gradually decreasing. And we feel that the daily dose is the preferred, more physiologic way of giving vitamin D. For breastfeeding, it's absolutely essential because what's transferred in the milk is not your 25-hydroxyvitamin D, but rather the vitamin D. So you would have the baby getting a huge dose through your breast milk, after taking the larger dose, and then it would continue to fall. So by the the end of that week, the 7th day, before you took your next pill, you'd have really very, very low levels of vitamin D being transferred to the baby. So for these reasons, we recommend daily dosing.
Mm-hmm. Number 12, if a pregnant woman tests low in the first trimester, does she need to take more than 4,000 IU of vitamin D to achieve a beneficial level through the remainder of her pregnancy?
So we had women who had profound deficiency, and they were on the 4,000 IU per day. And within a month, their levels really had achieved, marked improvement. And so we really, at this point, would recommend, just the daily amount of 4,000. Now, other people have looked at giving women in their 7th month of pregnancy a very large dose, talking about 50,000 IUs at one time, and then followed them. Again, you've got that kind of peak and trough. It may be that some women are going to need more than 4,000 IU, particularly if they have a higher BMI and if they have malabsorption. And so, in conjunction with an informed physician or health practitioner, you could certainly figure out what was needed to achieve a normal level. But for the vast majority of women, 4,000 will be just fine. And again, if a woman is planning on getting pregnant, she should correct her vitamin D deficiency before she gets pregnant.
Dr. Wagner, in our study and several others, it takes vitamin D, or the stabilization or the plateauing of the level takes about 3 months to get there. Like, you start taking your supplement today and you certainly start going up rather quickly, but it doesn't really reach its final level until about 3 months. Did you observe anything differently during the pregnancy?
We did, actually. And so women reached their steady state by, they were much improved by 1 month, and by 2 months they were at steady state.
Really?
And it
That's
may
good.
have to do with the pregnant woman's metabolism.
All right. Thank you.
Mm-hmm.
Number 13, 6,400 IU for pregnant women should translate into what serum level?
Well, so it depends if that woman's also, tandem nursing, if she's pregnant and breastfeeding. But let's assume she's not. So if you look at the grid, if 4,000 gets you to 40 to 50, you would expect that 6,400 IUs would probably get a woman to 70 or 80 nanograms per ml. And again, it also depends on, what time frame are you talking about and duration of that therapy. We're not recommending 6,400 IUs for the pregnant woman unless she has specific health requirements and she has, that she's been tested.
Mm-hmm. The appropriate dosing, what are the dangers of too much? And is there any effect on depression with vitamin D?
So certainly there's dangers of too much. So it's documented throughout the literature through the last century of what happens when you have excessive amount of vitamin D. We know that levels of well above 100, maybe even above 200 nanograms per ml are really what it takes to be having too much. But you're talking about at least more than 10,000 international units a day. And there are some studies that show that if you have stepwise increases, even up to 40,000 IUs a day, that's tolerated and not associated with the leading dangers of too much vitamin D is hypercalciuria. So you start spilling calcium in your urine, and then you overwhelm your kidneys, and you can get certainly you basically turn to stone. You start getting increases in your serum calcium. I would say that most people would aim for a serum level below 100 nanograms per ml. But on the other hand, we've certainly had women who've had levels above 100 without any problems. And I think if you look at the individuals who come from sun-rich environments where they're spending hours a day in sunlight, what you find is some of those individuals will have levels of 120, 140 nanograms per ml. Most people, though, in that sun-rich environment will have levels somewhere in the 60 to 80 nanogram per ml range. As far as effect on depression, there's some suggestion that vitamin D plays a role in seasonal affective disorder. We looked at it in our cohort of lactating women, and although preliminary data showed a weak association, in a larger cohort we did not find that did not hold up. And it may very well be that we were selecting for women who were not depressed because to enter a study, such as what we had, our lactation study where they were followed for 6 months, women who are depressed would be more likely to say no. So I think the verdict is not quite in on that. There certainly is some evidence from the neurosciences that vitamin D, there are receptors for vitamin D in the brain, and we certainly also have to think about vitamin D and the role of sunlight and ultraviolet light. And it may be that some aspects of vitamin D that are attributed to it in the brain may actually have something to do with the sunlight itself. So I think that there needs to be more data accumulating on that topic.
One of the things that we have noted also in the Grassroots Health study about the dosing and the dangers of too much is that above a certain level, right actually when you get to be in the 40 or 50 nanogram per milliliter range, it is really hard to get your serum level up to, say, 200 nanograms per milliliter. Each incremental 1,000 IU you take only raises your serum level a couple of nanograms per milliliter. So the effect of vitamin D on raising that, or supplements at least, on raising that level decreases the higher you get. So it is not a major tragedy. You should test, you should pay attention to where you're going, but it's not very common.
That's a really good point, Carol, and I agree with that completely. And that's exactly what we saw in our pregnancy study as well as our lactation studies. We've also seen that in the infants. So your body will really maintain, once you reach that certain level, it plateaus and
Right.
through a very, very wide range of doses.
Okay. Still more. I think we've already answered number 15. Let's start with number 16, Dr. Wagner. How late in pregnancy can they, meaning vitamin D, help the child? I just started a woman, looks like that she was due in 4 weeks, on 5,000 IU a day. Would that still help?
Yes. I mean, the fact that she actually made it to that point is great because certainly she was able to avoid preeclampsia, and maybe she wasn't going to have an infection. Sometimes though, women, in the last month of pregnancy can develop preeclampsia. They can develop infection, or after their membranes rupture, they can have something called chorioamnionitis, which is an infection of the lining, and so the baby can be infected. So I think that's certainly important, and also sets the stage. If this woman's planning to breastfeed, you want her to be replete in vitamin D instead of deficient. So I think that was a great move.
Okay. And to this, number 17, you've answered somewhat. How does taking vitamin D help with preeclampsia? Does it assist the fetus in getting the vitamin D needed?
So yes, and there's really 3 studies that have been published on the vitamin D, the role of vitamin D with preeclampsia, one by Lisa Wagner at the University of Pittsburgh, and then 2 by my colleague here at the Medical University of South Carolina, Chris Robinson, linking vitamin D deficiency with increased risk of preeclampsia. And of course, the vitamin D, that the fetus is solely dependent on the mother for vitamin D. So there's no impromptu production of vitamin D by the fetus. So the fetus absolutely is dependent on the maternal stores of vitamin D. And if mom's deficient, then her developing fetus is deficient. And the most severe forms of vitamin D deficiency in the mother, so in the single digits, what you can have babies born with rickets, with fractures, but we also know that they're at greater risk for small for gestational age. That was shown in the 80s. They also can have dentition, so their teeth can be affected. And there's something called craniotabes, so the fontanelle, the soft spot of the head, of the scalp, the skull, that's very wide, and so that has to do with vitamin D's effect on the calcium metabolism. But what we're just beginning to understand is vitamin D's effect on the fetal and then neonatal immune system. So stay tuned for studies coming out about that.
That's great. All right. How do you address vitamin D receptors that do not uptake vitamin D well?
So that's a really good question. And so in that case, it may be that if you have a genetic defect, you may actually need to take the 125. And so that's something I would urge you to go to an endocrinologist who's knowledgeable about vitamin D, because if you do not have the enzymes to convert it, and in this case it sounds like that, then you are going to be, you're not going to be able to get that over 20, and so you would also want to look at your 125. The other issue is if your cells are dependent on the 25 to make 125 in them, again, I would urge this individual to contact an endocrinologist who specializes in this area.
Thank you. And almost last, infants. We're on to breastfeeding now. Do infants breastfeeding need vitamin D supplementation early?
So yeah, so the American Academy or the American Association of AAP, American Association of Pediatrics, and then there's also the Family Medicine Association and the Academy of Breastfeeding Medicine. They urge babies who are exclusively breastfed or taking in less than 1 liter of formula a day that they start vitamin D supplementation within the first few days. That being said, that addresses the needs of the baby, but it doesn't address the need of the mother and why is it that the baby needs to be supplemented. And so our 6-year study funded by the National Institutes of Child Health and Human Development, NICHD, we are just, as I mentioned, writing that up. But what we did was we supplemented women with 2,400 or 6,400 IUs a day. And the babies of the moms in the 400 got 400. And the babies of the moms in the other 2 groups got placebo. And what we found, we weren't surprised. The 2,400 IU group, we had to stop that arm of the study early in 2009 because the babies weren't supplemented, and we knew 2,400 really wouldn't get the levels up. But so then the 2 arms remain, the 400 and the 6,400. And what we found is that the moms whose babies, the babies of the moms who got the 6,400, and they got no other supplementation, their levels were equivalent to the babies who were on the 400. And so what does that show? It shows that if you make mom replete, her milk will be replete, and the baby will get enough vitamin D through the mother. But again, this hasn't been published in a peer-reviewed journal yet, and we're just beginning to present this information. But unless a mom's levels in her milk are at least 60 in the 60 nanogram per ml, then the transfer of vitamin D through her breast milk will not be sufficient to achieve a level of at least 20 in the baby. So with all that being said, things are in flux, but in the meantime, while you're waiting for the results of this trial to be published, absolutely the babies need to be supplemented if the mom is not on higher dose.
All right. Let's go on down to number 21 with a question of, do you have any different recommendations for those with a strong family history of type 1 diabetes?
Well, I really don't, because I think that everyone should be vitamin D replete. And I think whether your family history is type 1 diabetes or obesity or some other autoimmune illness, I think that vitamin D deficiency, if your family is, has higher risk of cancers and that sort of thing, you really want to be vitamin D replete. And so I think you can certainly focus on that and say, gee, we really do have this history in the family. The data suggests that in the first year, so during pregnancy and in the first year after birth, is the most important for predicting type 1 diabetes. So I would certainly urge any individual who has that kind of family history to make sure that they're replete, and that before they think about pregnancy that they're replete. But I wouldn't just limit it to type 1 diabetes. I think really there should be a universal recommendation that everyone should be vitamin D replete.
Are there differences in the quality of the vitamin D drops, i.e. the liquids? Do you have quality guidelines or things to look for?
Well, I think I mentioned this earlier, but you really want to have a reputable manufacturer. They should be listing, what they have in terms of quality control, what the shelf life is. Each manufacturer has what we call overage, so they put more than, so if it says 400 on the, the bottle per drop, when it hits the shelves, it's going to have more than that, and it may be by 30% or 40%, so that by the time the expiration date comes along, that there'll truly be 400. So again, you really want to make sure that the company from whom you're buying the product has good quality control.
There, with regards to the vitamin D production, one of the other key issues that Grassroots Health has found out is also the testing of the components that go into the manufacture of the vitamin. And it's important that the vitamin manufacturer test all of those components to make sure that they don't have toxins in them. We are currently getting from the vitamin D manufacturers their standard manufacturing practices, what they are doing and what they are complying with, as well as what they do for testing all of the for any kind of toxins in the components, and we will be publishing that probably within the next 60 days. Okay, number
Great.
23, I think we can give a short answer to Dr. Wagner, although as you say, that's a much bigger topic. Is vitamin D2 as effective and safe as vitamin D3 for supplementation?
We think not. I think they're somewhat equivalent, but it seems that vitamin D3 is more effective.
Okay. Number 24, if the vitamins given for pregnancy contain vitamin A from retinol, is this really such a problem in possibly blocking absorption of vitamin D?
Well, again, you're talking about a fat-soluble vitamin, and so there's a possibility that you could have too much vitamin A and have toxicity from that. As far as how much you absorb, if it's a multivitamin, the studies that we've done, each mom was taking 400 international units from her prenatal vitamin and then the additional vitamin D. And I think that that's a really good question. And I don't know that we've really, we have all the answers. There very well may be someone like Dr. Robert Haney might know the answer to that question. But again, I would be careful how much retinol you take, because clearly there is toxicity associated with vitamin A.
And almost final, are there any other vitamins or minerals that work synergistically or in a complementary manner with the vitamin D that are needed? I wonder specifically about vitamin A and vitamin K.
And again, I think that's another really good question. And we were looking at so women who were on a multivitamin plus vitamin D. But there is some suggestion that vitamin A does work with vitamin D, and so I think there needs to be more research to look at that. There have also been some suggestions that vitamin K is also involved in those pathways, and they work synergistically. And again, I would look for answers to this question. Some wonderful questions, and I think this is really an example of somebody who has a lot of vision. I would see more information coming out in the next 5 to 10 years on that.
And last but not at all least, how can we encourage vitamin D level testing by all practitioners?
That's a million-dollar question. There are some who absolutely are going to say, "Oh, that's hogwash," and this is the latest hype that vitamin D is really, the new vitamin E or the new vitamin C, and people get all excited about it, and they're predicting that in 10 years this will all calm down and no one will be thinking at all about vitamin D. But I think the point is that vitamin D is not truly a vitamin. It's a pre-pro hormone. So it is, and our body cannot get it any other way by either making it in our skin via ultraviolet light exposure, ultraviolet B, or taking it by a supplement. Those are the only two routes. The amount that you get per day from your diet, a typical American diet, is less than 200 international units a day. And that is woefully inadequate. The amount that you generate of vitamin D after just 20 minutes in the sunlight if you have lighter skin, an hour in the sunlight if you have darker pigmentation. But whichever case, whichever scenario, if you measure your vitamin D levels within 24 hours, you're going to find that your body will have generated 10,000 international units. And so there is no way that you can get enough from your diet and from casual sunlight exposure. So I think that if you have a practitioner who's not interested, you could certainly go on the internet and you could find, select for practitioners who seem to have an interest in it. Or if you've been, going to the same practitioner and they're great, but they just don't see the vitamin D aspect of it, I think you could give them papers that are in well-established journals and say, I think you need to read this. Ultimately, if you have a practitioner who's not willing to have your vitamin D level checked or tested, then I think you're going to have to find some alternatives. Certainly, GrassrootsHealth is a mechanism where you can find out your level, and so there are some other options. And I would empower yourself to find that out.
Thank you very much, Dr. Wagner. We are going to close out this session of the thing right now. I do want to highlight, as Dr. Wagner mentioned, that Grassroots Health, one of the ways that we actually got started back in 2007 and then in 2009 when we started our D-Action project was because so many people were refused a vitamin D test, and Grassroots Health does offer that through their D-Action project. I thank you all as attendees for coming and participating, asking your questions. Next Tuesday at 10 o'clock, we are going to have Dr. Carlos Camargo talk with us about what vitamin D level helps prevent upper respiratory infections, which we are all susceptible to, especially right now in these winter months. A couple of his research papers are currently posted on our website at grassrootshealth.net that you can download and take a look at, and he will be talking about those. So thank you again, and take a look at our website, Grassroots Health, for our vitamin D program that we have, and certainly you can share this video with any of your friends. Again, thank you for coming.